Welcome to Swallow the Gap, the podcast that delves into the critical world of dysphagia practice and education. I'm your host, Dr. Tim Stockdale, and I'm thrilled that you have come to join us for conversations aiming to bridge the gap in understanding, knowledge, and implementation surrounding dysphagia intervention. If you're a healthcare professional, a student, or anyone passionate about enhancing the lives of individuals with dysphagia, then you're in the right place. Swallow the Gap podcast is a production of Gap Education, and we are predicated on an unrelenting mission to improve dysphagia care and education. Nothing we say is legal advice. Nothing should be taken without scrutiny. We strive for accuracy, but we do not imply perfection. We value diversity in backgrounds and opinions. Therefore, our guests will not always reflect what we believe. In fact, we may change our minds on topics as we learn more, because this is how progress is made. Through discussion, critical thinking, and open minds, we serve as catalysts for advancement in medically focused speech-language pathology. Julie Barkmeier-Kraemer is here with me today. Not only is she a friend, but she is a tenured professor in the Department of Otolaryngology of Head and Neck Surgery. She's the director of the Voice, Airway, Swallowing Translational Research Lab, or VAST. She's the clinic director for the University of Utah Voice Disorders Center, an adjunct faculty member at the Department of Communication Sciences and Disorders at the University of Utah. And I have a feeling there are a few other things that aren't on there, just because, Julie, you seem to have your hands in so many things. You do a lot, and you're always willing to bend over backwards to help. And so it's just a pleasure that I can get you on here for a while in the busyness that you have going on in your life. So thank you. Good morning.
Oh, thanks. Good morning, Tim. Thank you for inviting me to join you. This is exciting.
Yeah.
Congratulations on your new podcast.
Thank you much. Thank you much. Thank you for helping to make it successful. So I gave a little bit of information there. For those who don't know you, what else would you like for them to know? You've got quite a rich background.
Well, I think importantly, given some of the goals of your podcast, I think one thing I could share is that what I'm doing today, if you had said to me when I was in high school thinking about career options and where I would go in life, I would have laughed if anybody would have ever hinted that I would be working as a professor in a university or having served as an editor-in-chief for a journal. I just would never have imagined that I would be able to do the things that I'm doing today. And I do know when I chose a career path that took me into academics, I remember vividly the choice of, well, I thought I wanted to work clinically. What is it about academics that makes people enjoy it? And I have to say that I feel really blessed. I think the career that I've enjoyed, it wasn't planned. A lot of it felt accidental. I've felt most of my career that I'm an imposter among brilliant people, and always worried about people finding out that I was an imposter, not quite as smart as people might imagine. But I've learned everybody feels the same way in academics. It's a place where people end up that we get this privilege of training the next generation. It is incredibly hard to teach. And what I love about my career is I've been able to bridge the clinic to the academics. That has been a real joy for me.
Yeah, and I think that bridge between the clinic and the academics will be something that really resonates with many people today. I also, there are a few things that you said there. I didn't want to interrupt, but there are a few things that really struck with me. You had mentioned this idea of the imposter syndrome, and I've heard that from a lot of people. And so there is a principle in leadership overall. If I don't know myself, how can I lead myself? If I can't lead myself, how can I lead other people?
Right.
And so within self-reflection, at least in the validity of the Dunning-Kruger, I've seen it challenged lately, but those who know so much underestimate what they know, and those who know very little overestimate it. So this idea of the importance of self-reflection, to know yourself, to be able to lead yourself, and so on. So just as we're trying to lead the profession, in a positive direction. We see gaps in clinical practice, in research, and education. I think this idea of self-reflection is just very paramount. It's a big, important issue in that. And it's interesting to me that some of those who are most capable and most equipped to do this, they second guess themselves. Why do you think that is?
What a great question, Tim. I don't know the answer for everybody, but I guess I can speak for myself. I think when I was given the opportunity to pursue a PhD, it was really at the end of completing my clinical fellowship. And it was just, one opportunity after another presented itself. And the decision was, do I open that door and walk through it or not? And I think my tendency when I make decisions is to pay attention to what excites me.
Okay.
There's actually a book out there called Follow Your Bliss and the Money Will Follow. And I've never read the book, but I had a friend who highly recommended it. And I felt like, that title by itself really says a lot. And I have followed my bliss. So opportunities presented themselves. But why do I second guess myself? During my PhD, I think what I learned was I was capable of so much more than I expected of myself.
Mm-hmm.
And it was a real turn on to figure out that your confidence can grow when you feel the fear and do it anyway. That's another book. One of my mentors actually gifted me at one point. I think a lot of times people do self-preservation. We're really wired for survival. And so there is a limit to what people are willing to do to put themselves in the path of either succeeding or failing. And there's a different level of tolerance of failure. And I guess the way I was raised really was a huge factor. I also was an athlete growing up. I participated in team sports, and I have a bias. I kind of think people who have been part of any form of team activity, it doesn't even have to be athletics, where you've put yourself in a place where you experience failure and you learn that you can live beyond it. Those folks go through life being willing to take risks, put themselves in situations where they'll fail or they'll go on and they'll still survive. And there are others who just don't tolerate failure. And so I think there's a whole spectrum of ways of being in life. And I think we're shaped by what kinds of risks, failures, and the way we respond to those situations, how we're wired that way. And I guess I just got so used to failing and still surviving and going on anyway, the real turn on for me is when I actually have a success. On a daily basis, for every 9 failures, I have 1 success. And that intermittent reward for the 1 success really turns me on. And so I think that second guessing is probably just a habit that gets there to just say, am I making the right decision? It's just part of how you wire your mind when you're thinking through your options. I think that's kind of how I am on the inside anyway.
Wow, there's so much to that and a lot of things that I'd like to follow up on. But what I want to do is relate this back to people who are listening. I know you have made a lot of change happen in your life. You've done a lot of good. And I think you would skirt that with saying, well, I've had a lot of failures. But the people who have just accelerated in their careers, the people who have made big changes, I think we see the things that they're doing well. And they are so aware of all of their failures too. But the things we remember the things that they've changed, that they've done good. I've used this analogy or this commercial in a different show. Listeners, forgive me, but this Michael Jordan commercial where he's like, I took 8 billion shots or missed 8 billion shots.
Yes.
All that sort of thing.
That is a great commercial.
It's a good one. I mean, it's kind of cliche, but it's like, I like it. I like it so much. But he talks about all of his failures that he needs to succeed in. And it's this mentality that I think, on average, if you really want to do something big, if you want to do something good, that you're going to fail a lot.
That's right.
And it's how you frame that failure. So I suspect that many people who are listening to this are change agents, at least within their own lives and their facilities. I'd like to highlight that a little bit within you, how they can translate that to making things better, because it's not just knowing better. I mean, you can go to all the continuing ed, you can get a PhD and do so many things, but if you keep that to yourself and you don't try to extend that reach to the field as a whole or to your colleagues, you waste so much of it. So I mean,
Mhm.
I'd love to really hone in on that a bit. So would you mind telling to make this really relatable to talk about your background as a clinician a little bit? Like what settings have you worked in? What are your
Mhm.
passions clinically?
Yeah. Well, yeah, so I started out when I was an undergraduate. I remember my dad asking, "What do you want to do with your life?" And I said, "I think I want to be a teacher." And he said, "Oh, don't do that. There's no money in that."
Mhm.
His worry, of course, was if I had to support myself, he wanted me to be able to do that. And so he really encouraged me to go into medicine because I did love the health sciences. That was something that was pretty common across all of my siblings too. But when I started out pre-med, and I'm fifth out of six kids, all brothers as siblings, and many of my older brothers were in medicine. So I got to see their
Okay.
lifestyle, what that pathway looked like. A lot of the undergraduate pre-med courses were weed out classes. The mentality of it and some of the lifestyle aspects of it really didn't match for me. I ended up pursuing physical therapy first. And then as an undergraduate, I really loved working with behavior disordered kiddos, kids who were special needs populations. And I really thought that's what I wanted to do. And through my work in a group home, met up with two graduate students. One was in audiology and the other in speech language pathology at the University of Iowa. And they were the ones who really planted that seed and encouraged me to consider that our profession.
Okay.
I started out really interested in kiddos. And so that's what I set my sights on. And I did a lot of work in my training formative years in the profession with behavior disordered kids, kids who had hearing impairment, kids who are institutionalized, syndrome kids. That's where I started. And then in my training program, I got placed at the VA hospital with Adrian Perlman. And that placement changed everything. I met and worked with laryngectomy patients. Head neck cancer was a big part of the caseload. And that lit me up. I really loved it. And so that was my entry into the voice and upper airway part of our patient populations. And I had one of those coveted training programs at the VA back when they were first starting and nobody wanted them.
Their CFYs?
No, it was an
Oh.
externship. It's a
Oh,
the VA
oh yeah,
traineeship,
yeah, yeah.
and it pays your stipend. It's a coveted position now. And I had the blessing of working there. I think I stayed for a whole year. Where even when I went on to other externships, I got to go back and work with Dr. Perlman, and she was just transformative. She taught me how to think critically. She taught me clinicianship and how to also gain my expertise in that arena. And she also was a heretic at the time. That was before dysphagia was a thing.
Yeah.
And so she was the one who really got me going and taught me my fundamental knowledge in anatomy, physiology, and aerodigestive tract physiology, and how to do video fluoro swallows. And just really, I really credit her with that. That launched my focus, career, and passions. And from the training program, I was accepted into a clinical fellowship training at the University of Iowa Department of Otolaryngology. And at that time, the first cochlear implant was made. So I got to test the very first child implanted with a cochlear implant in the US
Oh
was at the
wow.
university, I think, was at the University of Iowa. I still remember that child, and he's now an adult and talks on the phone, and his cochlear implant experience has been very successful. So got to see that. I worked with craniofacial populations. Head neck cancer was still part of the package, and that was an inpatient, outpatient clinical experience. That started in 1988. I had the pleasure of working with an otolaryngologist who really is who I credit with influencing my decision to go back for my PhD. And that was largely catalyzed by me finishing my clinical fellowship, having started a research program with him
Hmm.
on his funded work. He got a grant and he needed somebody who is a doc student to be employed on his grant. But I had to be a student in the PhD program. And that was not what I wanted to do at that time.
Yeah.
But his way of working my mind was he encouraged me to just take classes. I didn't have to continue if I didn't want to. And I thought, oh, well, I could do that. And the University of Iowa was okay with that. So I ended up working, it ended up being a full-time job clinically from 1989. After I finished my clinical fellowship, I just continued in the capacity as a speech language pathologist in that program, inpatient, outpatient care, until I graduated with my PhD in 1994. And I also remained a consultant at the VA hospital. So it just was the way that was just such a unique opportunity. I wouldn't encourage any PhD student to do the way I did it. Working full-time clinically while also juggling your coursework and getting your PhD training. I just had people who are willing to be flexible with my schedule, and I didn't mind working weird hours, which I did. From there, I went to the NIH. And so my clinical work there was kind of put on pause because most of it was clinical research data collection, but it did entail assessments as well as additional novel tools that we learned there. And then when I went to the University of Arizona and joined their faculty, I also became a consultant at the VA. So I always had a hand in the clinic because I've always been passionate about clinical work. The VA was one of my favorite places to work with patients. Those are really my people. I grew up in the rural area of Iowa, and I think I just really resonated with a lot of the VA patient populations because of that. And I was there 14 years. So I did see people in my lab and helped with those coming through the clinic for voice and neurogenic disorders. I worked with community-based otolaryngologists. They did not have otolaryngology in the medical center at that time, which they now do. They've brought it back into the University of Arizona's Banner healthcare system. And then from there, I went to UC Davis, where I was in a Department of Otolaryngology. I worked clinically there again. And now where I am, I have this wonderful fusion of continuing to work in an outpatient academic medical center and also being the clinic director of a specialized clinic, being able to grow our voice, airway, swallowing disorder patient populations. We have just an incredible team of clinicians. So that's kind of the trajectory of my career and the kind of clinical experiences that I've had, all the while also treading on the other side of the fence on the academic side, teaching students, training the next generation of clinicians, and then also the work that I've done mentoring on a national level through ASHA and also the Dysphagia Research Society, some of the programs they have. I've enjoyed working with either junior faculty or students coming up through the ranks. So
very cool. Very cool. That's quite an evolution in the process. And there's what I like about it is how it weaves back and forth between clinic and instruction and academia, administration. So you have a very broad perspective on things from a clinical perspective, from an academic perspective, and from a business perspective, and a mentorship perspective. I mean, there's a lot there. And a couple of the things I wrote down that I think are very important to the conversation of helping to make the medical facets of our profession better. You talked about a background in health sciences. You talked about a VA placement and learning more critical thinking skills with Dr. Perlman. And so the three things that I really take from that I'd love to touch more on: the background in health sciences. What are we missing? Because we get, I think a lot of our work is very, very focused, and it's very focused on the neck up. But there's so many other things that go together when we're considering holistically on a broader level what's going on with the patient. Like how are our recommendations for the airway or the aerodigestive tract affecting them in another way? And without that education, I mean, how are we supposed to know?
Yeah. This is something that's really hot for our field right now. And I think for most clinical training programs, we face this real challenge that there's been this exponential growth in knowledge and transference of that into clinical care and application. And broad-based practices like ours, we span so many settings. I mean, we're now approaching about a 50-50 split between those who graduate and go into public school education settings versus those who go into more healthcare settings. And then we also cover the whole lifespan.
Mm-hmm.
I don't know that occupational therapy or physical therapy can really say that. I know they're also in the public school systems, but the vast majority of those professions practice in healthcare. And they're also a much smaller membership size. We're over 220,000 ASHA members. And I think PT is somewhere around 80,000, 85,000, something like that. So we by far are one of the largest professions. And we evolved out of an undergraduate degree. So it used to be you'd get your bachelor's degree and then you'd practice. Then we expanded to a master's degree. And now there's some back and forth about going on for a clinical doctorate or PhD. The PhD is really a scientific degree. That is not the degree to get if you want to just hone your clinical skills or get administrative packaging. I think that's more of a clinical doctorate degree job. And, the AUD was our first experiment with making that a minimum requirement. And just for those who don't know this, in the state of California, our profession resides in the Cal State schools. They split their University of California and their Cal State training systems so that our profession existed in the state California schools, not the University of California system. And they have a chancellor. They're all kind of connected. But because doctorates are not offered in the Cal State system,
Yeah, I remember that.
We nearly killed audiology in the state of California when we made the clinical doctorate the minimum entry degree, because now in order for that degree to work in that state, one of the largest memberships in the United States for our profession, you have to have a consortium arrangement between UC and Cal State programs to make that happen. And so there are things like that weren't thought through in my mind, and other challenges like the resource, the number of faculty and the number of resources that have to go into training now that it's a 4-year program. Weaving both clinical training in there as well as other training. It's a huge endeavor, a huge investment. And in the context of an academic setting that was not devised to be a business, we've got some challenges ahead of us. So as I watch the scenery, I look at the medical model as who's done it right. That's a clinical doctorate. Getting a medical degree is a clinical doctorate. Physicians are not PhDs, they are MDs, and they have no further time. They have a 4-year training program for medical school. That hasn't changed. But if you want to talk about a profession that's had exponential growth beyond what we've faced, that would be a great model to look at. So how have they handled that?
Yeah, what do you think works well from their clinical doctorate?
I think what they've gone through some gyrations over the last couple of decades, but I think what most medical school programs have settled on, and it seems to be working incredibly well, it incorporates the science of how do we actually learn as clinicians. They've created a combination of block training where core curriculum, fundamental knowledge you need at the base of everything you do, those courses are still there and they are fundamental and they're taught in a 12-month capacity with a series of guest lecturers. They don't do as much didactic training like they used to. I mean, they have some, and they've got lab-based training for sure. But what they do is they block case-based training and flipped classroom kinds of models where they pair the fundamental knowledge with its application in the clinical sciences. So that's one thing that they've done. And there are many models for how to do that. But as one example, what does that look like? Well, let's say in our field, I'll translate it to our field.
Okay.
We cover the lifespan, and we have patient populations we manage who have embryologic or syndromic changes. We should know about embryology. We should know about how genetic abnormalities influence the eventual outcome in a child that's born, say, with Down syndrome or with some form of chromosomal abnormality that's going to affect their ability to acquire language or to produce speech or to be able to swallow or breathe normally. That embryologic information manifesting in birth and first year of life could be paired with what we learn in craniofacial. also could have application to feeding, swallowing, to aerodigestive tract abnormalities and how that affects breathing and ingestion, our ability to transfer from oral to esophageal to the stomach. And from there, you can have case-based examples of cases we'll probably see in the NICU, where premature babies are born or kids are born quite early in life that have abnormalities that require support, and they're in the neonatal intensive care unit. They transition then to home health, et cetera. So you can start to package what you're learning academically into its application in a clinical realm. And also, let's not do that separate from understanding that we're going to work with other professionals. How do you work with the neonatal care professionals, physical therapy?
Do you care? This is fantastic. Let me throw something out there really quickly, because there are some people listening who might not be as familiar with case-based learning overall and a number of different things. So with case-based learning, one of the things that I like, you're dealing with case scenarios, patient's history and physical, you have this information from other providers and so on, and you get the problem. Like this is the presenting problem. So then you are given the context of what you're doing. You're not just learning about swallowing, not realizing what's the big picture of why this matters. It's forcing the integration with these long-term outcomes.
That's right.
And
the big picture of the person.
Yeah, absolutely. Yes. The interview, all of these other things, the things that are important to them, like the patient wants this XYZ outcome or whatever. And it's multidisciplinary. Like you were saying, it integrates other disciplines. And so that's one thing that I like about it. And so, but you would think like that, oh, that's really high level. That's something that we can only do later. However, there's so much scaffolding and so much support that even if you integrate that at an early level of education, you can elevate the students' knowledge in areas that they don't know yet and force this integration so early. Because what I can remember is I wanted to do dysphagia, but I didn't know the context for these things. I remember learning about all these components, but I didn't feel like it was until I went out and started working with cases that it made sense to me.
That's right. Yeah.
But this, you're saying it kind of cracks that egg a little earlier.
Mm-hmm. Yeah. And so, I think our undergraduate degree is not well utilized. It's inherited. And our profession has just traditional roots, didactic training, this, kind of silo topic training. And I think we need to start getting more innovative about how we coordinate our education and make it a little less like that. Like we're still in most of the accredited programs still have the mentality that there's one faculty that trains one topic and they have this full semester class. And the medical school isn't like that at all. You have a responsible instructor who sets up and organizes a course, but multiple instructors with expertise relevant to the topic at hand come in and lecture. They think in terms of how many lectures do I give, not what one course do I teach. Okay. And that mentality hasn't quite seeped into our profession yet in how we organize. And it would be a culture change and not a small task. Yeah. Having sat on both sides of the fence, there's a limit to what you can teach in a classroom. And what medical docs and medical school education have is they have the playground in the backyard, and that is the context in which medical students are being trained. But we don't have that same access for the health sciences. We have a lot more access to the educational systems. Those placements happen a little more frequently. In fact, most people who graduate from our master's programs as speech language pathologists have a much higher hit rate of completing their clinical fellowship in a public school system and then going into a healthcare system than those who begin in a healthcare system ending up in an educational system. And that just has to do with the frequency of availability. We've done a very poor job. I shouldn't say that. We've had very poor access to healthcare system training. And that by and large is probably due to the added workload on the clinicians working. They don't get added compensation for supervision. They do have an added workload. And they still have to maintain the same patterns of productivity that are expected of them for the business model of a healthcare system. And that's really hard to do when you're slowed down by the training of a student. So again, the integration of training into the context in which we're training our students would really help that. Partnering the supervision with those who are employed through the training programs, and maybe adding a compensation for that added workload, and also training our supervisors how to supervise. You just magically don't know how to supervise.
How to teach, yeah.
But yet we expect them to just finish this. Now I think there's a couple of classes online you finish, and then magically you know how to be a supervisor.
There's a 2-hour requirement, I think,
It's
every 2
ridiculous.
years or something.
It's just ridiculous. And just now that I've sat where I've sat in so many places, and having been somebody who trains students clinically across every level, and then also helping clinicians that work with me in our clinic to learn how to be supervisors and how to stage that so that they would learn how to set objectives, have realistic appraisal of the students, knowing how to take a student who's a learner who has no knowledge, which is usually the case when they come into your clinical setting, and to patch that into training them. That is hard to do. It's not easy. And there's a science to it that we aren't training people how to do. There's a lot to be done on improving how we do our clinical training and how we train our trainers.
That seems to me to be a really big pattern across our profession, with 9 diagnostic categories. Some are more related to each other than others, but still 9 areas. 5 or 6 semesters in graduate studies, a few core classes in undergrad, but a lot of variability there. And so you have that, and then the training model. You need to know how to train some if you're going to supervise, and you can't get that in 2 hours. It seems like we are spread so thin.
Yes.
For things that require a lot of depth, like you're working with instruction, like there's a lot there. You're talking about flipped classroom models and versus didactic and just so many things that barely scratch the surface of the complexity of this. And that is shaping what our future professionals are going to be like, what they're going to be able to do. But also, when you look back at swallowing disorders, there's so many gaps in just what we know about the basics of the body and typical physiology of not only swallowing, but of how the body works and how one thing impacts another. So I really love this integrated model that you're talking about, where I think it's much more efficient learning when students are doing case-based learning and are going hands-on, but also the cross-pollination of seeing how one area relates to another. Yep. Do you think that is one of the most promising solutions for us as a profession in getting more depth where we need it? Because for whatever reason, and this is not to cast blame on anyone in particular, we don't have it right now, not as we need it. And that is, that's a big reason why I want to do this podcast and pick your brain, because they're gaps. How do we fix them? I don't know how.
Well, I know at some point preceding this podcast, you and I were chatting about, I think we as a profession face a couple of things that are challenging. One is we lack diversity as a profession. And I think that is in some ways a byproduct of how we recruit to the field. But secondly, we face similar problems to other healthcare professions, and we are a healthcare profession. Let's start with that mentality. Yes, we exist in educational settings, but in those educational settings, there's a healthcare mentality to what we are doing to help children or even developmentally disabled adults to acquire functional daily living activity skills. And we're not the only profession that faces that challenge. So what if we take our undergraduate degree, and what if we pool our resources with all the other pre-health classifications, occupational therapy, physical therapy, nursing, pre-med, which often is in a pre-health, kinesiology type of atmosphere. What if we pooled our resources? And, education plays a big hand here, because again, let's go back to the challenge. How do we train our trainers? And there's a science to that. And if our graduating clinicians are going to be the future supervisors, we need to also weave in, how do we learn? Right. How do we teach how to do that thing we know how to do?
And you can tap into the parallels and the overlap with clients too when you're instructing them. And so it's not
and
Just
grow.
something to add to it. You can integrate it with what we're already doing.
That's right.
Find
And
some
to
learning.
then grow our partnerships across disciplinary, cross-pollination across disciplines is a good thing to plant the seed of early on. And I think then, physical therapy kind of does this. By the time you're a junior or a senior as an undergraduate, you're declaring an emphasis and you start to weave in some, I think we need to start applying the clinical training as a junior and senior undergraduate, but still allow for those who may come to our profession late in, like I did that. I came to our profession, I think I was a senior undergraduate.
Yeah.
And we do have the ability in our master's programs to take students in who have what we call deficiencies. They're holes in their preliminary training, but I think
I was quite deficient when I came in.
yes, well, I felt that way myself. But I think this gives us a wonderful framework for drawing from a larger diversity of individuals who think they want to take a career path that goes into the health sciences. It could help create more balance between the number of females and males that we accept into our graduate programs. It can help us draw from those who are not necessarily privileged white women, just, and I'm one of them right now. But there's a real advantage to having a better representation of our United States population serving the United States population where our services need to be delivered. And it brings diverse ways of thinking and cultural infiltration into our profession in a way that we need so that we become better as a profession and are more prepared for our service delivery in the future. I think we would really benefit from some kind of a cultural change with our undergraduate majors, as we call them. I think don't do away with the undergraduate coursework, improve it, make it more rigorous, and let's draw from a wider spectrum of people who are pre-health in their interest. I think that would be a really good starting point, and I think we could take it from there. But I think weaving in the clinical experiences early on, also the educational, how do we learn, motor learning, cognitive language, executive functions, acquisition of skills, that all would benefit across all health professions. So I think there's a partnership there for the future and less silo-driven education, so to speak.
Yeah. There's such a depth of information within there. Like, as you say one thing, my mind's going in one direction. I'm thinking more, critical thinking. And then as you go talk about something else, then it goes in another area. So the challenge for me is to pick what do I want to follow up with? Because there's just so much good stuff there. I wanted to ask, conceptualizing this, what would it look like? Like, how would it look differently? And you've already touched on more clinical training. You've touched on the integration with other professions. Oh yeah, how we learn, about how we learn in cognitive processes. What else about the undergraduate experience do you think would be different? And how would that help to prepare us or to elevate our knowledge?
Well, I think one thing I notice is our graduate students, we take the top 10% of the top 10% from undergrad and admit them into our graduate training programs. And we've had such great inflation in our profession. Our undergraduates come in thinking straight A's are normal. And I would argue if we look at our undergraduate major, I'm going to wager you a bet that the majority of undergraduates get close to a 4.0. They're getting A's and B's on average, and probably more A's. And that grade inflation and that perfectionistic attitude is unrealistic. I think we are not preparing our professionals to go in. Okay, so let's circle back to we've got to get good with failing.
Yeah, that's right where my mind was going.
Yes.
Absolutely.
And so where are people learning to fail and learn from it? Which is critical thinking training. There's no better way to learn how to be a critical thinking person than to have to critically think. So I think our whole undergraduate experience is really propped up with a lot of watered down information. And here's just some data to support that hypothesis. When I was at the University of Arizona, we had our undergraduate major grew to be about, 350 students at some point were declaring their major. And we added entry-level algebra as a requirement, a math requirement, because we discovered our undergraduate major, there was something missing with the accredited requirements of ASHA by the time they got done with their graduate training. And so we thought, well, if we add that to the undergraduate major, that'll solve that. We lost half our majors because they had to do math. If you're going to run a clinic, if you're going to submit charges, you better know how to do math. And so I would just say that the rigor of our undergraduate, our anatomy and physiology class, that's another example where I'm seeing online versions or lack of application where people are learning some of the parts, they learn the terms, but they have no idea by the time they get into graduate school how any of that works. And I have to reteach in graduate level coursework where I'm supposed to be focusing on the disorders and assume they have a working knowledge. I can't assume that.
Yeah.
Because there's such a diversity of really inadequate preparation at the undergraduate level. We can't teach at the level we need to at graduate school in 2 years to get them the knowledge they need to apply clinically. So I think changing our undergraduate, reformatting, reformulating, I think that would really help solve some of these problems, but it also requires an added workload. And I'm sensitive to the fact that my academic colleagues I don't think students have a clue how overworked they are and overburdened with the bean counting needed now by universities in order to keep the lights on and the doors open.
Well, so I am mindful of that and respectful of the extra work that it would bring into, but also as you earlier were mentioning teaching methods, flipped classroom, case-based learning, these types of learning, and I think we don't realize it because we are so used to sitting in a classroom and listening to someone lecture and taking notes.
Yeah.
But those things, they facilitate short-term memorization. But if you're
Right.
doing better teaching methods at an undergraduate level and forcing this integration,
Yeah.
it's going to stick more. And you
Yes.
have to reteach less. And so by teaching more efficiently, not just teaching more information, but by
Right.
teaching in a better method at the undergraduate level, you're making that carry on, you're making it more likely to carry on later into graduate studies and be something memorable because it's anchored in
Absolutely.
practice and it means something.
Well,
So,
it's more interesting too.
oh, totally.
Honestly,
It'd be
students,
fun.
it's
It is
much more
fun.
fun. I mean, we have a new generation of students who've actually got a lot more exposure to that computer interface learning. I mean, I've got kids now, they're teenagers but I've grown up with them in their school system experiences. And, the educational system has had to adopt this because they're losing teachers and they've got to get more efficient with their ability of meeting teaching objectives.
Mm-hmm.
And they're doing more engaged teaching with students. Students learn by taking more responsibility for the didactic part of the course, and the actual time with the teacher is spent applying that knowledge. That's actually a lot more engaging. It's harder for both parties because preparing the materials for a flipped classroom is incredibly labor intensive, and you have to do it a few times to figure out and anticipate where some of the downfalls will be.
Mm-hmm.
But I have such rewarding experiences with students when they come with the questions of having had to apply their knowledge to the experiences we're going to workshop in the class.
Yeah.
It just creates a much more efficient way of teaching and a more applicable understanding of why the information that they need to know matters in their patient care.
Absolutely.
So that they don't wear t-shirts that say, here's another day I didn't use my cranial nerves.
Oh, man. Yeah. Yeah. On old Olympus's towering top. Yeah. No.
Exactly. Well, and
Know the
people
mnemonic,
should
but what
have
does
a
it mean?
working knowledge of those. Why do they matter? Because what we call our oral mech exam is actually a cranial nerve assessment with
Well, it
some
should be.
speech
If we're
context.
absolutely, yeah, if we're doing
Yeah.
it right. So like, what does it matter? And so this is okay, brief tangent. I'll have to even label it as that. But for our clinical swallow bows, everyone's down on the clinical swallow bow. It's dead, they're down on it, like, oh, you can't tell anything from it, which absolutely know your limitations. Don't be looking at pharyngeal function. Don't be looking at anything, saying
Well,
what the tongue is supposedly doing when mouth goes. However, when you're assessing these cranial nerves, when you're
Yes.
looking
I
at,
think you can infer a few things if you know. I have to say that my clinical swallow eval, I am often not surprised if
yeah,
I do a fees or if I look at this person under the video fluoro. I must do a very different clinical swallow eval than the people who think they don't learn anything from it.
right. No, and I think that's largely what it is. What are we trying to get out of it too? And wow, this is totally, but it's good information. If you're looking at what you're talking about with the cranial nerves and understand the relationship of those nerves to the sensory and motor components and the
Yes.
sensory motor interplay of the swallow, then you can make some inferences because usually, doing an MBS, you're
You're
typically
testing your hypotheses from your clinical swallow eval.
right. But even if you see a certain dysfunction, you see an outcome, something
Absolutely.
that happens. And it could have a sensory component. It could have a motor component. And okay, these
Mhm.
nerves are involved. And I tested the sensory and motor component of this one. And I know that it's this sensory component is out of there. Then you have a better, more
Yeah.
focused treatment because
Yeah.
it's not just the what, it's you're hypothesizing about the why that's impaired too.
Yes.
Wow, this could be a whole nother thing, but it's so good getting people thinking about that. Anyway, so learning about cranial nerves in a way that makes sense.
Yeah.
So,
I just think there's a lot of I'm not a good memorizer, so I do have a
mhm,
bias towards problem solving.
same.
And I think one of the appeals for me with the aerodigestive tract is it's like automotive mechanics. If you know the parts and you know how they work together, you can problem solve your patients. You don't have to do a lot of memorization if you know how to problem solve.
Yeah, yeah.
But
No,
that's where having a core knowledge and some critical thinking skills can take you a long way. And I just really feel like I get concerned when students are like, well, this is the recipe I was taught.
yeah, yeah, yeah.
And this patient isn't conveniently matching that recipe, but this is all I know how to do.
Yeah,
Yeah, and that's why I also object to some of these recipe packages of treatment programs where we're getting certified to do the same thing over and over again without problem solving. And if I have one more patient come to me who's been trained in LSVT, but they have acquired all kinds of terribly hyperfunctional habits of doing that because the clinician only knows one thing about how to think loud, and that's to shout and strain without understanding how to do that in an efficient way, I will pull my hair out. And I want to just say, I'm a big fan of Lee Silverman voice treatment and Lori
yeah,
Ramig and Cynthia Fox and that whole team. The
yeah,
science behind it's incredible.
yeah,
There are just so many clinicians using it like it's a recipe, and that's the part that
yeah.
I'm trying to speak to here. Not the incredible program
Oh
and the
no,
way
no,
it's
no.
the science behind it has established its effectiveness is very incredible. But let's also not throw out the knowledge of how to do that in a way that's healthy for the patient and for the
Yeah,
clinician.
there you go. Before we wrap up in about 5 minutes here, the critical thinking piece that you mentioned, that's kind of been a thread throughout here. And you talked about how Dr. Perlman really infused that within you. And you talked
Yes.
about how we learn how to critically think by implementing that in our own, lives with our careers and learning to fail and learning to think through that and get past our failures. How else can clinicians now, where they are, really tap into that, whether they're in graduate school or whether they're out practicing?
Hmm.
What are some ways that we can exalt that a bit more?
The critical thinking.
Yeah.
I think most people are built to be critical thinkers.
Mhm.
I think that most people know how to find flaws. We're really good at error detection. Here's what's harder: positive detection, finding solutions. Um, so I think there are multiple ways to implement the critical thinking into your practice. And I'd say the first thing is learn to be a risk taker and not be afraid of failure.
Mhm.
Ask for a critical appraisal of what you're doing. Ask your patient, am I meeting your needs? Ask other colleagues, can you come and observe me for a little bit and give me some feedback on things I can do better? See if there is somebody who's an expert that is doing something really well with their patients. See if you can negotiate with your administrator to consult with them, buy some of their time to come and observe what you're up to and offer some feedback. I think a lot of people, unfortunately, are very worried that when they get critical feedback, they translate it into, I failed, I
Yeah,
stink at what I do, and they just beat themselves up.
for
And
sure.
that being afraid of the opposite perspective, which is invite opportunities to become better, find ways to execute what you're doing in a better way, ask for feedback, ask for resources, advocate for how that's going to make patient care better, start measuring your outcomes.
And I think applying that, if you're talking about somebody who's a graduate student and then they're in an externship and they're inviting feedback too, I think that as the one giving the feedback, framing it as well, like, you're doing all
Mhm.
these things very well. So you don't defeat that person, but you have to provide critical appraisal of things that they're not doing well. But if they particularly know how invested you are in them and they know the things that they're doing well too, it kind of mitigates how far that might offset or defeat them overall. I know you're speaking at it from the point of the one who is growing and learning. I was just thinking about that quick application from some of our externship supervisors and whatnot. But
Well, maybe they need to ask the students if there's a better way for them to learn. So another, I'm just going to flip that around. We're
yeah,
really good at giving students feedback. I think they get inundated with critical feedback through the training program,
yeah,
but not all students are the same learner. And so as a supervisor, I think it can be very challenging. If you only have one way to train,
hmm,
maybe there's an alternative way to train that a student can give you the opportunity to reflect on and consider. And so it goes both ways. I think most students know when they're failing. So if you offer the opportunity for them to critically appraise themselves first and hear where their starting point is in their mind,
interesting.
and then say, what are your ideas about? So I bet they're going to identify, they already know what their holes are. And
Yeah.
then if you put it out there to say, so what, I agree with these things, and here are some additional ones that I see. What do you think you need as a resource to get better at that? What is the knowledge that you're missing? What are the ways that you can be supported in your learning or your execution that isn't happening right now?
And that teaches them not only maybe what they could be doing better, but it teaches them how to critically think and how
It
to,
also is a role model for seeking feedback always. Just
yeah.
because you're the instructor doesn't mean you know everything.
Oh,
There's an individual learner in front of you that maybe
yeah.
you're a mismatch in your style of training to that learner, and that's getting in the way. That certainly happened to me. I had a
Okay.
semester where I had a terrible mismatch with a supervisor, and I would have failed that placement. And I knew I was failing. I knew I wasn't, but the modality of feedback, the interface with that supervisor was not a good match for me.
Sure.
And I never had the opportunity to discuss how could we make that as a partnership, because it is a partnership. You're partnering with your student. It's an agreement you've entered into. I'm here for you, and you're going to help me help you.
Yeah.
That's the understanding of that dynamic. So it works all the way through our career of training, from being a student to being a person who's training other students to us as a clinician working with patients in the context of wherever we are.
I like that word partnership because it roots us in a common goal
Yes,
and a common vision of what we're trying to do. It's not intrinsically antagonistic as
right.
sometimes it's perceived to be. You go into a session or you go see a patient as a graduate student, and you think, okay, I did really well. And then you come out and hear about all the things you did bad. But this idea of a partnership is, you're both trying to help you
Yeah.
get better, and you're trying to push the profession forward and so many different things with that.
And there
Julie,
are learning
yeah,
objectives. But if those learning objectives in a clinical context aren't clear to the students, they don't know what the performance targets are.
that's true.
And that's one of the most common errors supervisors make, is not having, first of all, realistic appraisal of what are the objectives that can be achieved in this context at this dose, meaning frequency and time together,
Hmm.
at the stage of learning that the student is. And so coming up with realistic objectives to say, by the time we finish our partnership of work together here, here are some skills and knowledge I want you to be able to execute. And here's how I'm going to know that you have those skills, because the following things will happen. If they know the target, then they know where they're trying to get to and how you're going to know as a supervisor that they got there.
That is a throwback to earlier when we're talking about this big picture perspective, the critical thinking with case-based learning, understanding the context of what it is, not just memorizing, but knowing where you're going. Because, I mean, within ourselves and with everybody, I think that it's easy to underestimate our ability to figure things out. If we know where we're going, and not just capitalizing and counting on those who are teaching us and instructing us to tell us, show us the path stone by stone so we can walk it. But if we know this is where you're going, we all have experiences that are different and these minds that are brilliant. And we can help to work that out too if we know where we're going. And I don't know, it just helps in so many ways to have this overall gestalt, not just the details, but like this overall gestalt too. Julie, thank you so much, Dr. Barkmeier-Kraemer. Everybody's like first name on here. I didn't even ask you at the beginning how you wanted me to refer you.
Oh, you and I have known each other a while. We're on a first name basis, so no worries there.
I know that. This was like when I was on a phone call with Dr. Martin Brodsky, or Marty, as his friends call him, and I just casually said, dude. And I was like, did I just say that? I had to go back but no, and he was like, Tim, totally past that. But it's so funny. But thank you so much. A lot to garner from this. Every conversation I get into, I'm like, I've got to cut it short. There could be 5 more podcasts on different topics that stem from this. But thank you for everything. If you have a 30-second parting message to whoever's listening, what would that be? Not to put you on the spot. But yes.
My parting message is, if you think that you're not good enough, think again. Be confident that you know what you're up to. Take those risks, fail a lot so that you can really enjoy your successes. And just remember, everything's all imperfection.
Imperfection?
Everything's imperfection. The pathway that I've taken didn't feel right most of the time. But when you look backwards, it looks like everything I did was on purpose. And I had some missteps along the way that were some of the sources of my greatest learning. Maybe that's the parting message I want to say, is in every cloudy day you experience, look for the lesson that you're supposed to be learning so that you can get it right moving forward. How about that?
That's excellent. I appreciate that.
And you can't go wrong.
There you go. Well, thank you, everybody. Dr. Julie Barkmeier-Kraemer. Feel free to reach out to me and I can pass along any questions. And I hope you all have a great week. Thank you, and see you next Tuesday.
Thanks, Tim.
That's all for today's episode. Big thanks to Dr. Julie Barkmeier-Kraemer. It's always a pleasure chatting with her. She always seems to be able to open my mind to things that I hadn't considered before. Please do remember to mark your calendars for April 20th for the webinar Dysphagia Management in Patients with Pulmonary Complications, ICU and Beyond, with Dr. Martin Brodsky, Joe Pontillo, Dr. Kendrea Grand. It'll be about 7 hours of content, including a live discussion panel. Sign up should be open very soon. I'm hoping within a few days, but it might be the end of next week. But if you get on our mailing list, go to our website, get on the mailing list, then you'll be one of the first to know. Going to have some really great promotions for the first 20 to sign up. We'll have student rates and early bird rates and so on. Go to swallowthegap.com/live courses, and there is a mailing list there that you can get on for first dibs. Again, thanks again for listening to another episode of Swallow the Gap. Please check in next Tuesday morning, and I will see you then.